And so now, without further ado, I am introducing our first speaker for today, even though she really doesn't need any introduction. It's a great pleasure to have Professor Miia Kivipelto with us this morning, and a recent Riemann Prize recipient. She's the deputy head of the Karolinska Institutet, ARC, and professor for clinical geriatric epidemiology at the Karolinska Institutet in Stockholm. Miia, the floor is yours.
Thank you so much. Very good morning from Sweden. My pleasure to be here today and talk about my favorite topic as well, risk reduction and prevention. And as we heard, it's really great that this topic is getting more and more interest globally. WHO always having the risk reduction guidelines, really providing a strong document for supporting the implementation, and I had the pleasure to participate in this important work. And now during my presentation, I will try to give a more feeling, what can we do? What is the knowledge really? How much we can prevent or reduce the risk? And especially I will focus on the topic of multi-domain interventions and the exciting journey we have now started when we are moving from finger trial to worldwide fingers. Let's see if my slides are moving on. I can't see that it is getting to the next one. So could I get the next slide, please? Thank you. Here we go. So the question was, one of the questions, how much can we prevent or reduce the risk of dementia? There are different estimates, as we know. And this is the most recent estimate from the Lancet Commission paper. The first author, Gill, will give a presentation later today and come back to this issue. But here can you see the short answer. Around 40% of dementia has been related to these 12 modifiable risk factors. So the list of risk factors have been increasing from the previous 7 to 12. And as you can see, there are several vascular-related risk factors as earlier, diabetes, high blood pressure and obesity already at midlife, physical inactivity, depression, smoking, low education, but even some more novel new risk factors like hearing loss, traumatic brain injury, high alcohol consumption, social isolation and air pollution. And it's important to remember that there is this important life course perspective. We know that the process in the brain leading to dementia and AD may start maybe 20 or 30 years before we can do the dementia diagnosis. So I normally say it's never too late to start to prevent dementia. It's important to remember as well that the evidence level for the risk factors is still different. For some of those, for example, for the vascular risk factors is already quite strong, whereas for others, especially for the newer ones, it's still a bit more limited. So more research is needed. If we move the discussion from risk factors to protective factors, we can think, what can we do to reduce the risk? And here can you see the list of protective factors, for example, healthy, balanced diet, and in general, active lifestyle. We have been studying recently even more novel risk factors, not included on the list of 12 risk factors. For example, loneliness and hopelessness, not only depression. These are increasing important during the COVID times. May I go back to the previous slides? Sorry, this is not, can I go back to the previous slide still? Thank you. Thanks. So these are getting more interest during the COVID pandemic because of the social isolation or the physical distancing and social distancing, and factors like stress and sleep disturbances. I see this more and more at our memory clinic, even among younger patients. So we can think that activity is good, but brain is also needing some rest. Impaired oral health, and of course, infections. There is a lot of research going on to understand, for example, how COVID-19 pandemic is affecting brain health, and can it even increase the risk of cognitive impairment and dementia on longer term. Then we can go to the next one, and now my slide is also working here from home. So really the question here is now, how can we move from the knowledge about risk factors to clinical trials and sustainable implementation? And here, as said, I want to focus on the concept multi-domain interventions. Giving this multifactorial heterogeneous background and etiology of dementia and late onset Alzheimer's disease, we can think that we probably need to target several risk factors and mechanisms simultaneously to get an optimal preventive effect, a concept what I call multi-domain interventions. The second concept I like to highlight is brain plasticity, meaning that everything what we are doing is affecting the brain structure and brain function, and this gives a kind of possibility for the prevention. Our lifestyle is affecting our brain health. What is still left here, if we take the next one here, is that one size does not fit all. We still need to understand more about the mechanistic foundation so that we can tailor the interventions to the individual risk profiles and make them even more effective. So I have been leading the FINGER trial, which is the first large long-term randomized control trial, really showing that it is possible to prevent cognitive decline among at-risk elderly persons from general population. Here we had 1,260 persons, age range 60 to 77 years, and these persons had increased risk for dementia based on some modifiable risk factors. We identified them with the GAID dementia risk score, which we have earlier identified, but these persons did not yet have any clear cognitive impairment. And in the FINGER trial, we used the FINGER model, like one hand and 5 fingers. We had physical activity, we had healthy nutrition, cognitive training, social activities, and management of all vascular risk factors. This intervention was 2 years, and it was compared with the regular health advice, which was here the control group. We are now ready with the 5 and 7 year follow-ups, and we hope to start the 10-year follow-up next year if the pandemic allows us. And that, I think, is very important to learn more about the long-term effects of this kind of intervention. Next slide, please. Here you can see the results for the cognition of this intervention. Global cognition was getting 25% better, more improved in the intervention group, and as you can see, there was clear improvement also for other cognitive subdomains. Executive function, how we are planning things, the multitasking, for example, 83% more improvement. Processing speed, how quickly we can do different things, 150% more improvement, and memory, 40% more improvement. We got also clear other beneficial health effects, 30% lower risk of functional decline, better health-related quality of life, 60% lower risk of other chronic diseases, especially multimorbidity, developing 3 or more other chronic diseases, and related to that, 20% lower risk of hospitalization. So we can really say that there were clear benefits both for the brain and for the total health. Dementia is not the easy outcome and not even feasible in these kind of early interventions when we are starting among at-risk persons, but we have been able to study the effect of the finger intervention on dementia risk score, the GAID score, which I mentioned earlier, but also Libra score. And as you can see here, the multi-domain intervention reduced the overall dementia risk, both according to the GAID and Libra scores, giving a signal that even dementia risk reduction may be feasible in these type of interventions, and of course can be related also on health economic benefits. We have been reporting that ApoE4 carriers, ApoE is the main genetic risk factor for dementia and Alzheimer's disease, can get clear beneficial effects of this intervention, which I think is a very optimistic and positive finding. We can't change the genes, but we can try to reduce the risk related to the genetic risk with these multi-domain interventions. And very new results from finger are showing that this intervention is also counteracting the shortening of the telomeres. And again, we could see this effect, especially among the ApoE4 carriers. And as you may know, telomere length is kind of a marker of the cellular brain aging. So it kind of gives a signal that this intervention is really doing something also on the cellular level. And just now we are doing a lot of research to understand more about the mediating pathways. For example, can we see changes on inflammatory markers, oxidative stress, vascular markers, Alzheimer biomarkers? That is, I think, very interesting area. Finger has been getting a lot of interest, and we launched the Worldwide Fingers 2017 to really support these other fingers globally, where the aim is really to adopt, test, and optimize the finger model in different settings and in different populations. A very key component here is the prospective harmonization. We aim to harmonize the outcome measures and the finger components as much as is possible so that it's easier to compare the results at the end and really share experiences, data, and plan joint dementia prevention initiatives. And I'm happy to tell that now at the end of 2020, we have more than 30 countries from all continents participating in the Worldwide Fingers Network. You can read more about the recent activities in this publication I have marked here. It's clear that the COVID-19 pandemic has had effects to Worldwide Finger activities, and really this has been one of the main focus this year. Try to understand how the pandemic has been affecting the lifestyle and the interventions, and here we have a very nice collaboration with WHO, Neurology and COVID-19 Global Forum. We have been developing a survey really addressing the effects of the pandemic, the lockdown, the physical and social distancing on lifestyle. And as we already heard, and as you in the audience also gave a signal, it has had an effect on our lifestyle. This is data, very new data from the finger participants in Finland, not yet published, but I wanted to share it with you. As you can see here, 62% of the participants are reporting less contact with family and friends. There are more unhealthy snacks. 12% are reporting that. But if you compare finger participants with the general adults in Finland, actually they are still eating in a more healthy way, kind of indicating that the finger intervention had more long-standing positive effects even during the pandemic. Less exercise, 1/3, 30% are reporting that. More sleeping problems, 15%. More remote contact with family and friends, 40%. So people are kind of finding new ways to get contact with their family members, which is positive. Here you can see the results for mood, memory, and quality of life. Luckily, at least in Finland, quite many of these persons are still saying that they have quite good or average health, memory, and quality of life. But if you see the self-evaluated change during COVID-19, I would especially like to take your attention to memory. You see that 15% are reporting worse memory during COVID-19, and that can, of course, raise the question, why is that? Is it more the general anxiety, maybe the sleeping problems, or something else? We want to study this more when we hopefully can have the 10-year face-to-face follow-up starting next year for the finger participants. Next slide here. Now, just to say that the COVID survey is now used within the Worldwide Fingers contest. Nearly 30 countries, around 30 countries globally are aiming to use that. And I think it will really give to us important information how we are planning the care, but also the interventions in the new normal. And this brings us to the new concept, e-fingers, which I would like to discuss with you. It's clear that we can't do the interventions exactly in the same way like we used to do before the pandemic. We need to use more remote visits and interventions. So how we can develop that in the future so that it can really be effective is some question what I would like to discuss you after my talk. And one more concept I would like to bring to your attention is the finger 2.0. How can we develop the finger concept even more? And here what we are planning to do is to combine an updated, more individualized finger lifestyle intervention with pharmacological interventions. And here we have already the first results soon ready from the MIND-AD trial, where we are for the first time combining the finger model with medical food among patients who have early Alzheimer, prodromal AD, and some vascular and lifestyle risk factors. And this really, for me, is giving the tools for the future trials where we are combining lifestyle and hopefully disease-modifying drugs. In the MIND-AD, we combined the finger packets with medical food, this multi-nutrient drink, where we have recently published positive results from the lipid diet study, positive results for cognition, functional level, and even for the brain atrophy. And this gives an important signal that nutritional interventions are important even in the early phases of Alzheimer's disease. And now, as mentioned, we want to see if we can get even better results if we combine this with the multi-domain lifestyle intervention. And we do not yet have results from the MIND-AD, we just closed the data, but we do have some positive experiences from the MIND-AD participants. Here you can see some of these quotes. MIND-AD gave a structure to a chaotic time after the diagnosis. I felt that I can still do many things. My brain is not too damaged yet. We became friends, we who are training together, and I'm part of the research. And I was very pleased to see the high compliance data. This is data only from Sweden, but as you can see, more than 70% could really attend and compliance with the interventions. And one important lesson from the feedback was that the social component was very important for the adherence. Final slide or step I want to mention for the future combination therapy. Next year, we are starting a new trial called MedFinger ApoE, where we combine this updated finger model with metformin. It's a drug used for diabetes and has been linked with Alzheimer's disease as well, with the reduced risk in epidemiological studies. Now we want to see if this combination gives even better results, and we are using ApoE for enrichment. Very exciting new trial design, really showing the way for the next generation of clinical trials and precision prevention. So this is my view for the future Alzheimer prevention and treatment. I don't think there will be one single magic pill really solving the whole Alzheimer challenge. I think it's more like a cocktail where the healthy lifestyle finger is always the basis. And now we are moving from the complexity to more to the personalized medicine. And hopefully in the future, we can add different medications to this cocktail. And here you can see my take-home action points. Multifactorial etiology. And I think we have evidence that the multi-domain interventions are effective and feasible. One size does not fit all. Now we are moving to the precision prevention, more tailored interventions and combination where we can combine lifestyle and pharma and using new technology, the concept e-fingers. And for the future, I really want to highlight the importance of global collaboration, sharing experiences, data, having joint projects, try to harmonize our methods and have long-term follow-ups, and start to implement and start to develop the pragmatic prevention programs. At the end, I want to thank different colleagues at different institutes, and I want to thank all participants who have been joining to our trials and all Worldwide Fingers members. Thank you for listening.
Thank you very much, Miia. That was brilliant. A fantastic overview of almost 10 years of hard work. Well, if not more before then. So thank you very much. I know that questions are coming in. Just an anecdote on the side as an example of how this pandemic is affecting our lifestyles, because we're doing this virtually now. I had to sit down so that you can see me face level rather than standing up. I was trying to do the good thing, stand up and be physically active, but no, I needed to sit down and and be sedentary for the duration of this this session at least. So let me maybe go to the first question that I find very interesting. And I don't know if you can talk or give some insights into this. What about surgical menopause as a risk factor for women? I believe that there is an association with women being at more risk, or more women having dementia. Is that the reason for it?
That's a very good question, and I think the sex differences in dementia is still an area what we should study more. We have been taking that as one of the important topic for Worldwide Fingers, because sometimes you need to have larger numbers to really see the differences. And of course, the hormonal changes has been one of the main hypotheses why women could have a higher risk. There are epidemiological studies that menopause and the sudden drop of estrogen levels can be a risk for cognitive decline, dementia, Alzheimer's disease. This is from epidemiological and experimental studies. However, we are lacking information from randomized controlled trials that the replacement therapy would really do the things better. There are also the side effects that are there. So that has been quite complex story. So I think it's always good to consult with the own doctor, especially if you have the very early menopause, as could be the question for the surgical things. So that is a bit different thing than the normal one. So I would say that for the hormone replacement therapy is always balancing the risks and the benefits that are there. I hope we will get more evidence from randomized trials. There are also new hormonal replacement therapies that hopefully will give less side effects. So this is absolutely an important area to study. I would also like to see more studies analyzing the differences in the risk profiles, lifestyle factors, psychosocial factors, how men and different women different in this sense as well.
Yes, fascinating topic, not just for me as a woman. Thank you, Miia. Another very interesting question is, do you foresee what are the challenges in trying to replicate your multi-domain interventions, particularly in low and middle income countries?
Yes, that I think is the very interesting challenge we have in Worldwide Fingers. We have the model, which I think is very much based on the 12 risk factors and what are the main components we can do. But it's clear, as I say, that one size does not fit all. What we do in Finland or Sweden, if you go to Asia or Latin America or somewhere else, you need to adapt and optimize the model. I think it really needs to fit to the society and to the culture so that it's sustainable on the longer term. For example, the healthy diet is different, or physical activity. What is the access to that? What kind of cognitive training you are doing? We use the computer-based cognitive training. Maybe you need to use something else in some other local settings. And that, I think, is the beauty here. We need to work with the local teams to really find that best fit to that society. So I think this is the key. We should not only take the finger model exactly like it is and take it to somewhere else. It needs to fit to the society. At the same time, I think the room for this kind of improvement is so big. I'm thinking low middle income countries, lifestyle interventions, education, taking care of vascular factors, healthy diet is something that is so important and can have so huge impact. So even small steps here, I think, would be a very, very important step. And as I mentioned in Worldwide Fingers, I'm so happy that we are now having countries from all continents that can really help us in this global effort.
We're certainly globally looking out for what the results of this are. Now, unfortunately, we've run out of time. There are tons of questions coming in for you, Miia. We will try to get back to many of them at the end of the session. But for now,
I'd here, so thanks.
Yeah, thank you. So for now, let me introduce our next speaker. We're moving from finger to singer. Our next speaker is Chris Chen. He's Senior Clinician Scientist and Associate Professor at the Department of Pharmacology and Psychological Medicine at the National University of Singapore and the Director of the Memory, Aging and Cognition Center at the National University Healthcare Center System. He's the principal investigator of the Singapore geriatric intervention study to reduce physical frailty and cognitive decline, also known as SINGER. And I think he will tell you all about this now. So Chris, please, the floor is yours.
Good afternoon, everybody. At least this afternoon in Singapore. A very warm welcome to the ADI, and I'm so sorry that the meeting is not in Singapore as planned. I can tell you that it's a nice, slightly cloudy but warm day, and it would have been wonderful to have you all here. So I am grateful to the organizers for inviting me to talk about our experience in learning from FINGER and setting up the SINGER trial in Singapore and our experience in doing this. I'm not managing. Oh, okay, here we go. Thank you. So I think we all know that Asia and the other parts of the what used to be called the third world, will be the epicenter of the epidemic of dementia in the coming years. The largest increases in dementia burden will be in Asia, and we really need ways to prevent cognitive impairment and dementia moving forward. And of course, how do we do this? And you've seen this slide before, probably many times in this meeting, and we're very grateful to Gail and her colleagues on the Lancet Commission for very brilliantly illustrating how we can look into the problem of potentially preventing dementia. So as you see, there are 12 recognized ways. And I think I would just like to emphasize that if you look at the list here, during midlife, which I'm glad to see only ends at the age of 65, there are a number of potentially modifiable risk factors, including vascular risk factors like hypertension and lifestyle issues like obesity. And as we go on into later life, there are other risk factors which are potentially modifiable. And you've heard from Miia that what her team did in view of the somewhat disappointing results from previous lifestyle modification studies, which really only focused on modifying one lifestyle factor at a time, that if you have intensive multi-domain lifestyle intervention, as you can see here in nutrition and exercise, plus cognitive training and monitoring of and management of vascular risk factors over the 2 years of the trial, you could find that there was an impressive result. You can see here, not only in terms of the composite neuropsychological score, but also in executive functioning, processing speed, and in memory. Now, this result really knocked the socks off the audience at the AIC when Miia presented this. And in fact, it was such a tremendous result that I recall to my surprise being summoned by the CEO and chief executive of our university hospital to be asked what is going on. Is there really a way of preventing dementia? And why aren't we doing anything about it in Singapore? So I was embarrassed to say that we hadn't at that time conceived of doing a trial. And one of the problems, of course, was that we weren't sure whether these finger interventions, which worked in Finland, would be workable in Singapore. I think that some of you will know that the Finns are very fond of saunas, and many of you here in Singapore would know that Singaporeans prefer to be clothed, and we also have an obsession about food. So would fussy Singaporeans who may not wish to have the same kind of interventions as the Finns, would we be able to have a similar trial in Singapore? Well, with the encouragement of the university, the first thing we did was to meet up with Miia at the Toronto AIC meeting in July 2016. And as you can see, here we are with Miia and my colleague Ed Koo. And Miia very kindly agreed that we should press on and try and work together on this. As you know, there was the Worldwide Finger Consortium meeting in 2017, which we took part in. And importantly, I had the opportunity of visiting Finland in 2017 and 18. And here's a picture of me being introduced to new Nordic cuisine. And I was really pleased to know that in Finland, when they have new Nordic cuisine, it is not pickled herring and cold cuts, but actually we had fish curry. So my hopes were raised. And what we then proceeded to do was the finger pilot study, which took place from 2018 to 2019. On the way to Finland, I did read about what were the differences between Finland and Singapore. And as you can see, there were some interesting differences and similarities. We have the same amount of people, but Finland is much larger, of course, and it also has more universities and, curiously, more members of parliament. I think many people in Singapore already feel that 92 MPs is a lot, but Finland has 200. Finland also has a lot of saunas, and if you're here in Singapore, you know we don't really need saunas because Singapore is an open-air sauna, and we have important visitors to summits. But we also share beautiful buildings and scenery, and I'm very sorry that those of you overseas are not here to join us in Singapore this year. But please do come. So we went on to do the Singer pilot study, and we based this on, of course, the finger study. And this was a randomized control study of these multiple interventions in elderly patients. And I was very, very grateful and fortunate to have colleagues such as Jay Henry, Summer Su, Effie Chu, to run the other components of this study. And we also got funding from Professor Brian Kennedy in the NUS Center for Healthy Aging. And what we were looking at was the feasibility and acceptability of finger versus Singaporean adaptations of the finger interventions. And this study wouldn't be possible without the support of the Memory Aging Cognition Center, which I run, and for which we're very grateful that the National Medical Research Council of Singapore continues to fund. And to begin with, I really need to thank all my colleagues at the MACC, some of which I hope are on this call, because without their help, we wouldn't have been able to run the study. The study design was very simple. We screened subjects for eligibility. They had to be within a certain age, they had to be mildly to moderately frail, and we randomized them between the finger intervention and the Singer interventions. We had outcome measures at 3 months and 6 months, and the whole trial took about a year and a half. Sorry. Here you see the recruitment flow chart. We had to screen about nearly 300 subjects to get the 70 plus subjects that we randomized, and you can see the groups were randomized with very few people who dropped out. What were the differences between the different types of management? In terms of vascular management, the finger intervention relied upon the excellent primary healthcare system that you have in Finland, where the study team would simply write a polite letter to the general practitioner to say, well, there are some issues, could you sort it out? And that was it. So in Singapore, we felt that this might not be optimal, so we decided that to have the study team initiate and manage the vascular risk factors and initiate treatment as necessary. In terms of cognitive training, as you heard, the finger group relied on computer testing. In Singer, we thought that this might not be so easy in the elderly, and so we relied on paper and pencil tasks. Could you move? Oh, sorry. And in the diet portion, the Singer diet was simply an Asian adaptation of the principles of the New Nordic diet adapted for Singaporeans. This busy slide simply tells you that the groups were very equivalent in terms of vascular risk factors, lifestyle, and baseline assessments. There was a small difference in education and history of hypertension, but not really very significant. In terms of the primary outcome, I'm very glad to say that both the finger and the Singer interventions were feasible and highly acceptable to most of our subjects. The only significant difference was in cognitive training, in that those who were assigned the computerized training had difficulty doing this at home if they didn't have a computer, even though we gave subjects thumb drives to try and use it in public computers. In terms of efficacy, there really wasn't much difference between the two interventions. There was a small difference in terms of weight between the groups, again, very small and probably of no clinical significance. But otherwise, everything was equivalent, except for vascular risk factor control, especially for blood pressure. As you can see here, the Singer intervention resulted in more subjects having good blood pressure control at month 6 compared to the finger intervention. And this was particularly the case in those who had poor blood pressure control to begin with at the start of the study. In terms of cholesterol and diabetic outcomes, there really wasn't much difference. I'm very sorry, there seems to be a lag in this clicker. Okay, so at the end of the day, we decided that because they were equivalent, the preferred, sorry, let's go back one slide. Okay. The preferred intervention was, much to our surprise, finger, 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 except for vascular risk factor control. So where do we go on now? Well, we were ambitious and decided to use the finger pilot study to develop a much larger study in Singaporeans. And we're very glad to report that this proposed study has been funded by the National Medical Research Council, so that we will be able to recruit in the next year or so 1,200 community-dwelling elderly Singaporeans at risk of dementia to put them through a 2-year interventional program, either self-guided lifestyle management or structured lifestyle intervention. Plus, we are also able to investigate what Miia mentioned, the mechanisms behind these effects, in that we're going to perform MRIs and we're going to do blood tests as well as genetic tests to decide what is really underpinning the improvement in cognition in subjects on active intervention. And these are our colleagues in this large collaborative program, colleagues from all over Singapore, from many different institutions, both clinicians and basic scientists. And importantly, we also are including health economists to see how these results can change public and clinical policy development. So it's a great privilege to be working with all these wonderful colleagues in Singapore and across the world on this project. And of course, we've had COVID. COVID did have an impact on the SINGA pilot study, but I'm very glad to say that we were able to overcome these challenges with the cooperation of our subjects as well as the dedication of our staff, so that we managed to collect most data. Nevertheless, we realized that the new normal is going to be difficult, in that safe distancing and social restrictions will impact on how we perform SINGA in the future. So we're working very hard to develop appropriate methods to recruit, intervene, assess, and retain our subjects through more emphasis on digital recruitment and consent, web-based study materials, digitizing our assessments so as to reduce face-to-face meetings, to use podcasts and apps to try and educate and retain our subjects. And this, I think, trial is even more important now because, as Miia mentioned, we may be facing a tsunami of dementia, not just because of the social distancing and loneliness and the lack of access to physical activity and medical facilities, but also because the virus could directly damage the brain. So we are pinning our hope on a digital platform, as you can see here, which will allow us to do health monitoring, to evaluate and hopefully predict what's going to happen to our subjects. We're going to insert a lot of educational content and advice, and we're going to use these apps to better communicate with our subjects and hopefully perhaps even do a trial better than the usual way that we've done a trial. We want to help subjects improve their health literacy, to facilitate self-management, and therefore improve health outcomes. Thank you very much for your attention.
Thank you, Chris. It was really great to see this adaptation, or you know, how finger can be moved to different cultural context, and to see how you do this in Singapore. And also very interestingly, the impact of COVID-19, like how we now all have to adapt to and are inventive in the sense to continue our trials. We're a bit behind schedule, but I see there's still many questions coming in. So it's thank you to the audience for being so interactive. Maybe just two quick understand or follow-up questions to SINGA specifically is one question is, do you plan to include any outcomes or participants, like younger people with MCI? And can you talk about the makeup of the study team? Are these mainly medical doctors and nurses that can actually influence or impact people's health behaviors? And yeah, if you can be quick in with those answers, I'll try to find another quick one before we go on to Gill. Thanks.
Thank you. So quickly, we are going to try and recruit people at risk of dementia. So not patients with dementia already, or people at the more severe end of MCI. And we're also going to try and recruit the elderly. So perhaps somebody who's young and has MCI, I don't know how you define young, it may not be be included in the trial. Secondly, the personnel who are running the trial, I mean, in general, there will be, of course, doctors, but in general, there will be hopefully bright, young, personable coordinators who will engage with our subjects and not be too distant and dogmatic. We want people who are going to be able to encourage our subjects to adhere to their intervention and to work with them to achieve better health outcomes.
Thank you. And I have another good one. Do you think there are, or there might be genetic factors that might change the response or the way finger or singer works in Southeast Asia versus Finland?
Well, as Miia has said, even in patients with ApoE4, there was a beneficial effect. We have less ApoE4 frequency in Southeast Asians compared to Finns, but you're actually right. This is one of the research studies we're going to do. We're going to try and develop a risk factor profile, a genetic risk factor profile, to see whether we can identify who might benefit. And if I may go back to the previous question, obviously anybody in the audience who feels that they're one of these young, bright people who want to help us perform the trial, we're very, very pleased to hear from you.
Thanks. And maybe as a follow-up, Chris, another question was also around the differences that you saw in vascular risk factors for singer and finger, and now they may not be genetically, but can you elaborate on or have you put any more thoughts on why you may have found these?
Right. Well, there's a very high prevalence of vascular risk factors in Singaporeans, especially hypertension. And what we were trying to do, which I should have mentioned, was that we were trying to implement a more rigorous blood pressure regime. We're adopting the SPRINT protocol to reach a SPRINT target. Now, some of you may have heard that there's been a wonderful new trial called SPRINT, which has established that a blood pressure target of 120 systolic is superior to conventional target of 130 or 140. So that's what we intend to do. And I think that one of the reasons why the study team was able to achieve this was that we're more attuned to this particular aim. But of course, I think with time, maybe this will become the standard, but we're trying to achieve that.
Yeah. Thank you. Very fascinating from a public health perspective, and also, nice seeing the how cardiovascular public health measures can impact on brain health. We could go on forever, but let's keep the other questions that are coming in for the discussion session afterwards. So thank you very much, Chris, once again. And I now like to introduce you to Gill Livingston, who's a professor of older people at the University College in London. She leads the Lancet International Commission on Dementia Prevention, Intervention and Care. I'm sure you all know Gill. Thank you very much for being here this morning. And Gill, the floor is yours.
Thank you very much. I'm going to move from talking about individual interventions to thinking a bit about policy, and I'm building on the Lancet Commission. I really enjoyed the other people's, I really enjoyed Miia and Christopher's presentation. It's made me look at my watch tracker, and I see that I have managed 148 steps this morning in the several hours since I got up, and I think that that's definitely COVID, because if I was in Singapore, it might take me a bit longer to get to the lecture room. I want to say, first of all, that the Lancet Commission is a commission of people around the world, and while I've led it, there are numerous other people whose names are on the slide who've done lots of work in it, and it's their work as well. And in particular, I want to mention John Huntley, Andrew Summerlad, and Nahid McAdam, who have worked with me in the systematic reviews and meta-analysis and the path calculations. And we've spent many, many hours in our desks at UCL when we used to go in there to work and to do this. And we've also we're supported in this work by UCL, by Alzheimer's Society, by the ESRC as part of our United Kingdom Research Institute, and Alzheimer's Research UK. So just to go back as to why we think that dementia is potentially preventable, or potentially it may get worse, is that while there are clearly, and as you all know, more people with dementia in the world as there is an older population, if we look at the prevalence and incidence, there's been a decreased prevalence and incidence in some countries, mainly in Western Europe and the United States, but there's been no decrease and a possible increase in East Asia, in Japan, South Korea, Hong Kong, Brazil, India, and also Brazil and India. So dementia is potentially, but not inevitably, preventable, and it could increase if the risks begin to rise. And the reason why we think that, going right back to one of the reasons why we think that it's potentially preventable, there's two things that happen in dementia. First of all, there is neuropathology which causes the dementia, but it doesn't inevitably cause dementia. So if you look at this graph, and you look at the bottom one, at the bottom graph, you can see that in the bottom one, that dementia is in a group proportional to the amount of neuropathology. So people who have more neuropathology are more likely to have dementia, and people who have less are less likely, and the more neuropathology makes more severe dementia. But if you look at the individual graphs, which consider people who have, look at people individually, then there's a huge overlap between the people in the top left-hand corner who have no dementia death and those people who have severe dementia. So on an individual basis, it's possible to have considerable amount of neuropathology without having any dementia. And we think that that is due to brain reserve. So any policies suggest that we would have then anything to change dementia could do two things. They could increase brain reserve, and it could decrease the deposition of any neuropathology in the brain. So people have shown you our diagram twice already today, so we didn't see each other's slides first. But basically what we did is in 2017, we decided to consider this life course approach to dementia. And we thought that was very important to consider it throughout the lifespan, because if we look at something like high blood pressure in middle age is a risk for dementia, and so is obesity in middle age. But in late age, people as they develop dementia lose weight and their blood pressure drops. So in late age, having high blood pressure and obesity probably means you're not developing dementia, whereas you'll be at higher risk at a younger age. So we thought it's very important to look at it at different stages in the life course because there's different risks. And we started off by saying, well, let's think of our what's already established, and we decided we would define that by using the National Institute of Health risk factors and the National Institute of Clinical Excellence in Britain risk factors, and we found 9. We then met again after the first commission and discussed the evidence, and we added 3 risk factors which we thought there was enough evidence to establish that they definitely were risk factors. That was traumatic brain injury, pollution and alcohol, getting to 12. and we did not add others, and the particular ones that we spent a lot of time talking about were sleep and diet. So we decided that because increased sleep can seems to be a risk for dementia, and decreased sleep also seemed to be a risk, but that's not biologically plausible, and that some of it was reverse causation. So people, as they are developing dementia, have disturbed sleep, and some of it might be due to underlying risk factors. So, for example, people who are developing physical illnesses may have problems with sleep, or people who are depressed. With diet, equally, we felt diet had something to do with dementia, but couldn't really establish any particular element from the literature, and found that the literature was inconsistent. So when we said there are 12 risk factors, we know that there are 12 established risk factors, but there are several other risk factors which probably relate to dementia, and we're waiting for more definitive evidence. And there are many, many risk factors which have been mentioned in 1 or 2 studies, but the weight of evidence is not enough. So these are the risk factors. I'm not going to dwell on them very much because mainly because people have already talked about them, but just to say that I think that some of them are more established. There's been a lot of work on social isolation since 2017, and it's consistent around the world that social isolation is related, and social isolation at age 40, 50 and 60, having less social contact, is related to the development of dementia. So I think there is some more evidence about them, and indicates that it really does make a difference. The evidence in a recent meta-analysis is that loneliness was not a risk factor, and I think that that's probably related to the heterogeneity of what loneliness is, rather than the fact that it is, of course, bad for your mental state in many ways to be lonely. We've considered these risk factors, and and we considered it in the whole population, because this talk is really about population that I'm considering. And so we worked out the population attributable fraction, which is a fraction theoretically prevented by eliminating a risk factor. And it is worked out by the relative risk, which we established from meta-analyses, and the prevalence of a risk factor. And it's a worldwide figure that we give. So just as Chris talked about how interventions have to be tailored, the figures we are giving are worldwide, and they vary between different populations. So if there's more hypertension, then it's likely to have more of a population attributable fraction. So in our worldwide, if you look at the path, the relative risk makes a difference, but so does the prevalence of the risk factor. So something with a high prevalence and a relatively low relative risk can make a huge difference, and a high relative risk with a low prevalence makes less. The one that comes out in both times as the highest is hearing, which both have which is a high relative risk and a high prevalence. We also considered, and I think it's really important, is communality. People are not like lab rats or mice, and lab rats and mice keep getting cured of Alzheimer's all the time, every year. And so far, unfortunately, these things that have cured mice and rats haven't done much in humans, and that's probably because humans are a bit more complex. And if you just look at one individual risk factor and don't put into consideration that they tend to cluster, then you get it suggests that that one is is causing a lot of the dementias in the world. So, for example, hypertension, obesity, lack of physical exercise, and diabetes tend to cluster in the one person. And you have to look at all of these together. And this is the way that you calculate it. I'm not going to go through the actual equation, but any of you can look it up in the Lancet and try it yourself. And we now have it in spreadsheets to help us. So here is a diagram you've already seen twice. I'm not going to keep showing it, but what it's taught me, and I hope it's other people will agree with me, is that putting things in a pictorial form really, really makes a difference. In the both Lancet reviews, we talk, oh my God, it says the client has disconnected. That's really worrying. Sorry, but in both Lancet reviews, we talk about the risk, and we put them, and we go into great detail how we calculate it. But what the message everyone takes away from it is the picture. What am I supposed to do about the slides? It says client has disconnected. Can you help me, please? Fantastic. So the risk factors, are they the same for everyone? No, they're not. All the evidence over the world is taken from cohort studies, and despite the fact that over 60% of people with dementia now live in low and middle income countries, about 80% of the studies are from high income countries, and even within the high income countries, they're mainly from white participants. So the risk varies between countries, and our overall message will vary. And the risk varies within countries, and they cluster around inequality. So, for example, in high-income countries, in Black, South Asian and minority ethnic groups are more liable to develop dementia. Vulnerable populations are more likely to develop dementia, and low and middle-income countries. People in low and middle-income countries tend to have now higher risk, for example, more cigarette smoking and more diabetes, and therefore are more likely to develop dementia. Can you give me the next slide, please? Thank you. So in 2019, the group of us looked at the 1066 data from Martin Prince, and we published in Lancet Global Health using the 9 risk factors, the risks in lower and middle income countries. And we found that the risks, that these 9 factors accounted for even higher numbers of cases of dementia in low and middle income countries than they did in a worldwide estimate. That's really important to know, because it suggests in low and middle income countries that dementia is even more preventable. And the sorts of work that is done in finger it would make even more difference in, say, in Latin America. And I'm busy trying to think about whether there could be an acronym which is as good as SINGER, but I don't think it would fit in any of these countries. Can I have the next slide, please? So when we look at all of these risk factors, we can think about individuals, but it's difficult for individuals to change, and it usually requires both an economic and an educational capacity. And when we think about what governments can do, that can make a great deal of difference. So these are our recommendations in policy. We'd like to keep thinking about how policy could make much more difference than in individuals. So in education, all children should be provided with primary and secondary education. And currently, about 40% of children in the world do not have education past the age of 13. Since we did the original work in the Lancet in 2017, several groups have looked at provision of hearing aids and found that people who use hearing aids, these are not randomized controlled trials, but cohort studies, but people who use hearing aids do not have an increased rate of dementia, and have the same as the population who do not have hearing impairment. And that seems to be very important, because it suggests that when we first published it, a lot of people said hearing had nothing to do with it, that losing your hearing is just a prodromal sign of dementia. But if it were so, just using hearing aids wouldn't be expected to decrease your risk. However, since it's not randomized controlled trials, it may be that the sorts of people who use hearing aids are just a different sort of people, but it's a very, very hopeful sign. So one of the things that we should consider about is policy to prevent hearing impairment, to prevent loud noise. We should have campaigns and about the stigma of hearing impairment. So now it's still very stigmatizing to wear hearing aids, and yet I don't know what the percentage in the world, but I'm going to suggest that 50% of people in the world are walking around wearing earphones to listen to music or listen to podcasts at all times. And just as glasses used to be 50 years ago a big stigma and no longer are, we ought to be thinking about the stigma of hearing aids. Also about the availability of hearing aids, which can be afforded, and how they are provided, because they're much easier to use. In cigarette smoking, policy makes a huge difference in the high-income countries who've reduced dementia. In most of them, cigarette adverts are now illegal. There's certainly been a reduction in it. And not smoking inside in public as a health policy makes a vast difference, and availability of smoking cessation. I'm going to link obesity, hypertension, diabetes, and physical activity together because they are, and local availability of healthy foods at affordable prices makes a huge difference to what individuals eat. Walking in cycle-friendly environments, places where they have pavements, places where it's easier to walk and it's easier than it is to drive, and places where people think that they will survive if they walk or cycle make a huge difference. So the environment and policy makes a difference. Traumatic brain injury has been very much in the news as football and rugby players around the world are talking about epidemics of dementia. And traumatic brain injury can, a lot of stopping of that is using policy, seatbelts, cycling helmets, sports protection. In the States at the moment, there's a campaign refusing to allow children to head balls in practice or to not use helmets. And as the leader of the campaign said to me, if you're a professional football player, then you as an adult, you both have capacity to make a decision and you have helmets and you're paid a lot of money. If you're a child, you're just heading a ball. Now, we don't know that heading a ball as a child causes dementia, but it's not likely to do your head much good, and campaigns to consider sports protection can make a difference. And in terms of air pollution, legislation to help clean air can make all the difference. And there's one study out and another study that is currently with the referees showing that policies which have reduced air pollution have made a difference to the cognitive profile of the whole population. So I've got a really important message. Individuals can take control and can do a huge amount, but governments can do even more. And it's much easier to change behaviour. Next slide, please. So I want to say that not only is it not just about individual intervention, but it's also about the way society is structured. And we've seen that a lot with COVID, where the most vulnerable are older people in care homes throughout much of the world, but not in all countries, have died disproportionately. It's been more than a third of the people who died in the UK of COVID have lived in care homes, despite less than 1% of the less than 0.5% of the population living in them. There's been more deaths throughout the world in people in minority ethnic groups. So culture, poverty and inequality are obstacles to change, but they're also the drivers of the need for change. One of the things I think about randomized controlled trials is they tend to recruit people who understand the concept, who have the availability and who are very well motivated. And over again, for example, in the finger trial, we find that the non-intervention group does a lot better than expected because these are people who take up policies. Those are most deprived, need the change most. And that was shown in the Hatties trial, where the most deprived people did much the best in reduction. And they're likely to derive the highest benefit. As societies, we need to think beyond promoting individual health, blaming people for not being able to be healthy, and begin to improve the circumstances in which people live. Thank you. Next slide. Thank you. Recently, we published in a couple of months ago in Lancet Healthy Longevity a cost study of individual, moving from policy, but individual interventions which were but which were state-led, and we costed it in England because you can only do costing in an individual place, how much it costs for a doctor or a nurse in these places. And we found that if everybody was offered free and available screening, middle-aged people or young, old, for hearing aids, anti-hypertension, smoking cessation, and prevention of diabetes rather than treating diabetes, then the hearing aids, antihypertensives, and smoking cessation would lead to an 8.5% reduction in dementia prevalence in England, because some people already have these interventions, and a 2.4 billion year saving in care, in health, social, and unpaid care. So these interventions are not only morally right, not only important, as dementia is the most feared disease for people, individuals, and families, but should actually save money. And Health Economists did the sums, not me, but they've now developed a methodology in the UK, and we could help and provide that so that people could do that in their own countries. Preventing diabetes was too expensive and not worth it in terms of qualities just for prevention of dementia. I'm sure that it would be worth it for prevention of other things. And it's interesting, as Miia points out, these healthy lifestyles don't just make a difference to dementia, they make a difference to other illnesses and to hospital admissions. But it's not just ethically right, it's not just right for people as individuals in the way that we all want is to have more years of healthy living, but it saves countries money. And I think it's a really important message that we should all be bringing back to our governments. The World Health Organization should be talking about ADI as an international organization, which is the ear of so many governments should talk about. And it really is a time that we can make a difference and there can be a revolution. Next slide, please. Within the UK, Public Health England have already implemented some of our findings, and the middle-age check now includes an individualized assessment of cardiovascular risk for dementia, so that people are told you are more likely to develop dementia because you have this, this, and this is what you should change. And their indications are that people do begin to change their behaviour on a more individual basis. Next slide, please. Overall, I think it's really important to be ambitious about prevention. Trials are short with relatively small numbers of people, and therefore it's difficult to show that they prevent dementia. I mean, Mia's going for the 10-year follow-up, and it's a very long-term basis to try and see what happens. However, results of cognitive reserve modification for whole populations or high-risk populations are much more hopeful. We must keep in mind that over the last 20 years, there's been a 25% reduction in the incidence and prevalence of dementia in these high-income countries, which have particularly made differences in cigarettes and in hypertension, and more of the population are educated. So policy changes are very likely to be the most powerful changes. And I'm going to leave you by talking about ways that these have changed in earlier times. I'm going to talk about John Snow in Britain. And none of these things that I've shown pictures of had randomized controlled trials, but our earliest epidemiologist, John Snow, at the time of cholera, mapped where the cases were in the maps. So this was before anyone had seen the organisms that called cholera, or even knew that they caused cholera, or even knew they existed. He found that there was only one family that were not in a particular area, and he went to see them. He was much more interventionist than any of us. He went round and they said, well, they used to live at Broad Street, which is where all the other cases were. They'd moved away, but they thought that the water tasted so good that they went back and collected their water from the Broad Street pump. He talked to his colleagues and said that this is what's causing the cholera, and people didn't believe him. So he broke off the handle of the Broad Street water pump, and since then there's never been an outbreak of cholera again. Next slide, please. So I'm saying that we must get over we must work with people saying, do not wait for definitive proof from randomized controlled trials that policy can make a difference. The evidence now is overwhelming, and this is a time to act. Thank you for your attention. I'm leaving you with a picture of the campus in UCL, and just to help us all think about the broader world. I'm sorry that I'm not in Singapore, though I'm pleased I'm not jet lagged. And I look forward to talking to all of you, and particularly with Chris and Miia, about the work that we are all doing together to try and make a difference to dementia.
Thank you.
Thank you very much, Gill. This was fascinating and very comprehensive overview, and kind of ties up that whole session from, starting with what do we know, what's the current evidence for the risk factors, how might we research them some more or adapt interventions for different cultural settings, to then the big question and the elephant in the room is what are the policy changes that are required so that we can really bring those benefits to the general population. We're a bit behind schedule, and we have so many brain questions coming. So it will be really a challenge to select a few. So please, dear panelists, be as brief as you can as I shoot questions your way. The one that comes from earlier in the session was actually on. It seemed that the finger intervention trial is very similar to what you would do in diabetes. In diabetes trials, you then also add metformin to the mix in some of the trials. So Miia, can you maybe comment on the similarities between diabetes prevention and dementia prevention? And then Chris, the question was also, will metformin trial be added to Singapore? And Gill, feel free to add any cost considerations to that question, please.
Thank you. It's a good question, and indeed, we know that behind many chronic disease are partly shared risk factors. So diabetes and dementia are sharing risk factors. Actually, the finger model comes partly from the diabetes prevention study, with some of the addition of the more brain focus, like cognitive activity and so on. So we are also talking about integrated interventions. We could, like as I showed, partly, of course, have the same package and try to use the infrastructures what are there for dementia risk reduction as well. About metformin, yes, I don't think that is needed for all. So the idea is, as I said, more precision prevention. Some individuals may need some more pharmacological means. It can be, like Chris mentioned, more intensive treatment for blood pressure, or metformin for those who have insulin resistance or pre-diabetes. So this is the idea in the metformin, that we add metformin for those who have this kind of phenotype, not for all. This is how I see the future. The lifestyle is always the basis, and then it can be even more individualized, and then we add medications when needed. Final point, what I think was really important, what you mentioned, Gill, individual choices are important, but the policy, the society, making the healthy choices, the easy ones, is so important. So I really hope that this growing evidence can facilitate the policy making so that we can make dementia prevention-friendly societies.
Thanks, Miia.
Thank you. Yeah.
Metformin in Singapore, in Singa, that would be wonderful. So, metformin has been touted as being a very multi-potent drug. So there are studies or planned studies to see whether it's anti-aging, and that there's a potential that it could be anti-dementia. So we have discussed this with Miia and Left, and certainly we would like to consider doing such a trial, but If anybody from the NMRC or funding agencies in Singapore is listening to this call, please look favorably on any further application. We'd love to do it.
Okay.
Can I say something?
Gill, was there? Yes, please.
Yeah.
Yeah. So if we go back to our life course diagram, just in your head, I'm not suggesting put a slide up, then of that 40%, 20% are caused by 3 risk factors in order of importance, and they are hearing, education, and smoking. So vascular risk factors are really important, and what happens with diabetes is really important. But it's dementia is not diabetes; it's more complicated and even more difficult. So, preventing all the things that prevent diabetes are really important, but we must be thinking about things that help keep us cognitively active, as well as cigarette smoking, which also I think poisons in addition. So it's very much diabetes is a bit of it, but the majority of it are other things which are considered in finger and singer as well.
And if I just may quickly add, I think this is the important, the multi-domain concept and life course perspective, the complexity of dementia. So keeping this in mind is not one thing that will solve the whole thing.
I want to get at least 2 questions in before we have to wrap up for the next part, and that is a question for Gill on air pollution. So this is a new risk factor that was added, and from a policy perspective, potentially a powerful one. Can you tell the audience in a minute or so a bit more about what type of air pollution and what kind of policy changes you see?
Sure. The literature in air pollution is quite heterogeneous, but it seems that it doesn't really matter what you pollute the air with, it all has the same effect in the end. If you look at them all, it's just the particles in the air that matter. And obviously, people who live in areas of high pollution tend to be people who have less choices. But if we go back to the animal models, if you have high air pollution for a rodent who has no other risk factors, and they begin to get tau changes in their brain. So it does look very convincing that it is the air pollution. So policy changes have probably got to do a lot to do with differences that can be made that will make our future more likely in terms of clean energy within that. And probably one of the only better effects of, maybe the only a better effect of COVID has been a reduction in air pollution. So it's the wood fires in some areas, traffic, aeroplanes, all the things that cause air pollution. We can think about less of it. So policies which reduce car driving, which also increases physical activity, decreases obesity, and decreases hypertension. So it affects many of the areas in it, and areas which and policies which decrease the use of polluting fuels in terms of burning coal, but also using petrol, diesel, and lead-based lead-based fuels. So it depends on individual areas, but a huge amount can be done to reduce air pollution, and that's something that we have not much control of as individuals, but we have huge control of society.
Thanks, Gill. And the other question that I wanted to get in, it's just the elephant in the room, and you'd mentioned it all in your presentations or in your comments. COVID-19, it may be a blessing in disguise for air pollution. It will reduce our social interaction, and I recall Miia saying in the beginning, the social component was one of the most powerful recipe or ingredient in it all. What is your overall take-home message or take on COVID? What do we need to be aware of, and what might it help us with in taking the agenda forward?
I could just start quickly that yes, we can see that it is not only the direct effect of the infection, but the indirect effects, the long-term effects that may really have big effect for the brain health, because it's affecting our lifestyle, may affect the management of the risk factors and so on. So how can we adapt the interventions in this new normal situation? I think it's very important. What we could see, as I showed in the finger, that the social component was so important. I believe we can use the technical tools, remote control, but we need to take into account the importance of the social component. I don't think the technical thing can totally replace the face-to-face connection. So I think we need to be creative, and this, especially I'm thinking some older, more frail or cognitively frail person, how can we guarantee that they also get access to these interventions? So that is not only for some selected groups where these digital tools are available. So I think that diversity is important. Finally, I believe that our efforts are needed more than ever, given this new situation and the lockdowns. We need to adapt the interventions and care to this new normal. So here I again think that the global and joint efforts are really needed.
So from our experience, whilst face-to-face meetings are important, once you have the face-to-face meeting, and I think it's important to emphasize that the finger and stinger interventions are not individualized. They actually take part in groups. So the groups actually get on with each other. I was really quite astonished that in the groups that we had, they all exchanged WhatsApp numbers, and they got on with interacting themselves. So I think that our elderly, if they are motivated, can actually overcome many of these obstacles. But we just have to get them started.
Yeah. I think that, as we'd all agree, that most of COVID has been a disaster for people who have dementia. And I think it has shown the difference between countries which protect older people with dementia, where there hasn't been an excess risk of death, and most countries who have not. And it's really important to keep with the vulnerable people, and not people who can be sacrificed. Sending people into care homes with COVID is completely unacceptable, and lots of excess death. And we really have to, every time that there is a threat like this, now we have to start thinking about the older people to begin with, who tend to be more vulnerable. So I think it's a really important message about that. Other than that, we don't know if there is a long-term threat to brain health from COVID, but we suspect there might be, and there might be an epidemic. It's really important we keep finding out and going through with this. And it's also important we try to have the positive effects of COVID, there's very few positive effects, but we try to think about reducing pollution, reducing unnecessary travel, and neighbourhood kindness, which has been one of the effects of COVID. So let's point up the negative and try and tackle it, keep an eye on everything, and keep the positive.
Yes, thanks, Jill. You mentioned it, or you pointed out the vulnerability of the older population in the pandemic. And we've spoken about vulnerable or at-risk populations for dementia risk reduction. That links to another question on whether in the UK there were any particular policies focusing on low income or vulnerable populations, and how that focus might help in reducing risk overall, if we focus on vulnerable and populations and at risk.
I don't think there has been a massive focus in the UK on vulnerable and at-risk populations, and if we look at the studies, it's been the reduction in people with more education and who are high income. And I think that the more education is both because it increases cognitive reserve, but it also increases your opportunity and to make good choices, both because you have more resources and also because you're much more able to pick out from the mass of information, much of which is misleading, what's correct and what's misleading. So I don't think it has been in the past. I don't think the UK has many examples for this, except for our wonderful NHS, which has meant that anybody, that's true. It's true in some other countries. It's also not true in many others. That it means that the policies such as a midlife check is on illness is there for everybody. Hearing aids are there for everybody. Blood pressure medication are there for everybody. However, having said that, it's made a huge these things made a huge difference, but still, people who are socioeconomically disadvantaged and people of minority ethnic groups get less of these, and that's there's a variety of reasons for that. It can include less ability to access them, and less ability and less belief and trust that in some of the minority ethnic groups, that the doctors either care about dementia or that they're there to help you and things will be kept confidential and private. These are things that we can really begin to make a difference to in the future.
Okay, thank you. It's really I did not expect this to be such a difficult task to in short period of time to select the last few questions that we can still address. And I'm mindful to hand over or introduce our next the next segment or the last segment for this. So I just wanted to wrap up, give each and every one of our panel members this morning a chance to say famous last words. Any take-home messages that you want to give the audience. And we can maybe address some of the other outstanding questions in the chat in writing throughout the rest of the conference. So any take-home messages on how we can all reduce our risk? If you can make a wish for the population, what would you say?
Ladies first.
Anyone? Ladies first.
I thought you could start, Chris. You are in Singapore, so please go ahead.
Okay. Well, I'll give an unashamed plug for Singer, because I know we all know what we need to do, but the problem is getting people to do it. So if there are any colleagues out there, any organizations in Singapore which want to help us show that this particular structured intervention, which is safe, affordable, is actually effective, we welcome you to join us, so that the sooner we finish this, the sooner we can benefit Singaporeans, and through that, all of Asia. Thank you.
If I may continue. Oh my God.
Yes,
so
please,
2
quickly.
points. I think Prevention is treatment. That is the way what we can do to really manage the dementia epidemic. We know already what we can do. Now I think it's more the how, and it's more, I think, the worldwide thing is we are trying to find the ways to implement and then influence the policy. So making the healthy choices the easy ones. All hands, fingers. It's a joint effort that is needed.
Okay, so my final message is that the audience here are powerful people. They are health professionals, they are policy people, they're people whose voices count. We need all of you. We need all of you to be talking about prevention, talking about the hope for dementia and how we can really, really make a difference now. And talking to your voluntary groups, to your government groups, to your health settings and social care workers that you work with, to really begin to make a difference. You are powerful and know powerful people. And everyone here goes out and tries to do 2 or 3 things, to talk to people, to make a difference. This will make a global difference. So we need you. That's what I'm saying. We all need you. I think Miia and I walk around the world trying to tell people, or sit in our own living rooms and try and tell people there's things we can do. We need everyone to be ambassadors and to do it for themselves and get their organizations and their countries to do it. And thank you for giving us this opportunity.
No, thank you for being here, for fascinating talks. It was great being here with you. I'm now handing over to the fascinating Amalia, who will introduce the Poco Poco dance. Thanks, audience, for listening, and please stay on and do the Poco Poco dance. Bye.
Yes. Thank you, Catherine, for the introduction. That's really interesting. Many people said it's Poco Poco. But that's okay. The name is Pocho Pocho. I know it's a little bit challenging for some people, but okay. Thank you, Catherine, for the introductions, and again, thank you, ADI and ADA, for this great opportunity. Hello, everyone. I am here on behalf of my lovely colleague, Alzheimer Indonesia, across Indonesia and across the world. Now it's watching. It's really nice that they are supporting you endlessly. So I'm really excited to tell you guys more about Pocho Pocho. Yes. Pocho Pocho dance, known as senam ceria. Senam ceria is exercise, and ceria is fun and happy. So it's like happy and fun exercise. It's a popular traditional dance originated from Eastern Indonesia. And dancing Pocho Pocho is an easy, inexpensive, and practical method in the community, especially in Indonesia, to preserve and improve the methods, practical method in the community to preserve and to improve the executive functions in order to maintain the independency and quality of life for the pre-elderlies and elderlies. Pocho Pocho ceria, we call it in Alzheimer Indonesia. So ceria is happy, fun. So it's happy, fun Pocho Pocho dance. So Pocho Pocho ceria move created by Alzheimer Indonesia risk reduction team. And they are all here, watch us from Indonesia and around the world. So it's supporting Indonesian from around the world. And we have research from Dr. Ria Maria Teresa, Scientific Committee of Alzheimer Indonesia, that shows that by doing this Pocho Pocho dance, 30 minutes, 2 times a week, will can improve your brain plasticity and executive functions of type 2 diabetes mellitus patients with mild cognitive impairment by 37.5%. This Pocho Pocho ceria dance is also shows at ADI conference in Kyoto, Alzheimer Europe conference in The Hague, and also some conference and meetup in New Zealand, Brunei, Malaysia, and many more. So most probably some of you is familiar with it already. And at that time, maybe you're a little bit shy to dance with us on the stage or on the floor. But now you have your own virtual stage at your home in front of your computer. And yesterday, I read the ADI newsletter of the day one of the conference, that during this pandemic and all this time, you have a lot of virtual meetings. And in this conference, it's not always sitting and listening and discussing. So now we would like to invite you to stand up. I will stand up, and I hope you guys also stand up. Come on, stand up, stand up. Yes, this. And I heard also from the previous sessions that Catherine make a polling that we have really less physical activity. So this is the special about the conference. Like, we're not always sitting. Now we are standing up. I'm really looking forward. Now we give you time to take your mobile, your smartphone, and make a pictures of yourself preparing doing pocho-pocho or video and share with us. I also look the pictures of ADI's staff yesterday doing the brain gym. It's really amazing. So you guys can adapt her and show us. We will watch 2 videos after this. The first one is the pocho-pocho tutorial. So we will show you the step-by-step tutorial, the move of the pocho-pocho, then you can follow. After that, we will show you the guide, the video guide, the dance guide, so you can dance together with us. And we hope, don't forget, you can turn on your video now. I will turn on my video now too. So I will send that I dance pocho-pocho too, and share with us in the social media and tag ADI 2020, Alzheimer Indonesia, and Alzheimer Disease International social media. So let's do it together and show our move with us. Let's watch the video 1 and the video 2, tutorial and dance move.
Sudah mulai lupa, bingung tidak fokus, marah-marah curiga yang berlebihan. Pikun jangan pikun, pikun jangan malu pikun, pikun jangan pikun, pikun jangan malu dengan pikun.
Hi, so how's it? My breath is a little bit, yes. So it's really short introductions. If you want to hear more, if you want to see more about the long versions of the dance, you can go to Alzheimer Indonesia YouTube and you can find the whole introductions and the whole move. I know, sorry, my breath is catching up my breath because I'm really, really doing it. And if you see, and the move, some of the move is also inspired by Indonesian traditional dance. So it's traditional dance from West Sumatra, tari piring. So it's inspired by many things. And also if you see that you can do it together as like line dance. Yeah, the line dance, people have it everywhere. This is the line dance of Indonesia. So you have the movement, you have to repeat the movement, and then you do it together with your friends. Of course, at this time, maybe it's not possible, but like this, we can do it online together, and it still have fun. So thank you very much. Don't forget to show us your move. I'm really looking forward, especially the ADI staff in London. Is also, I believe you guys are doing that, and all of you. So thank you very much for joining us. We look forward to see your move in social media later, or send us the private message if you don't want to post in social media. And thank you very much. Regards from all Indonesian Alzheimer Indonesia team, and enjoy the rest of the conference. Thank you.